Working in behavioral health or managing an organization in the industry can be challenging. Regulations are constantly changing, and staying compliant is harder than ever. That's where the Behavioral Health Association of Providers can help. BHAP is a national association for those who work in behavioral health or addiction treatment. One of the ways we serve the community is by offering educational opportunities such as CE-based webinars and our Certificate in Addiction Treatment marketing. BHAP also provides advocacy information so you can stay on top of new laws and regulations that will affect how you do business. Our members benefit from simple, effective, and relevant resources that keep you focused on what matters most, the health and well-being of your clients. Helping small and mid-market behavioral health providers access compliance resources and legal education, BHAP is the leading and unifying voice of treatment programs. You can find out more information, as well as sign up for our various newsletters, on our website, www.bhap.us.
Hello, I'm glad you could join us today. Welcome to the webinar 2021 Advocacy Update, Moving On from COVID. My name is Angie Fiedler-Sutton, and I'm with the Behavioral Health Association Providers. Did you know that BHAP sends out regular advocacy alerts? BHAP members also get a special one once a month. More information on this is on our website. And now, it's my pleasure to introduce our presenter today. Andrew Kessler, JED, is founder and principal of Slingshot Solutions, LLC, a consulting firm that specializes in behavioral health policy. His clients, past and present, include the International Certification and Reciprocity Consortium, ICNRC, the California Consortium of Addiction Programs and Professionals, CCAP, and Faces and Voices of Recovery. With 20 years of policy experience and over a decade in the behavioral health, Kessler is a fixture in circles that advocate for substance abuse treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office of National Drug Control Policy, the National Institute on Drug Abuse, NIDA, the Substance Abuse and Mental Health Services Administration, SAMHSA, and other federal actors. Andrew has written legislation and report language adopted by both the House and Senate Appropriations Committee and has presented orally before such bodies as the Scientific Management Review Board, the National Conference on Addiction Disorders, and the College on Problems of Drug Dependence. Andrew, thank you for taking the time to present today. With that, I will hand the webinar over to you. Yep.
Thank you, Andy. There's Mike, 17 months into the pandemic, and we're still facing technical difficulties. Nothing is easy these days. Good afternoon or good morning, based on where in the nation you may be. I saw some people from Louisiana. I saw people from the East Coast, some from the West Coast. So thank you for joining us. Just a word of warning that Angie did not give. I, like many of you, am still stuck in my home office. So that means the pleasures of my home are to be shared with you over the next 55 minutes, which includes my 5-year-old Beagle and my 10 and 14-year-old children who do not have camp this week. So any noises in the background, any disturbances, I apologize for in advance. I ask you to bear with me and know that I won't have to ask or plead too hard for your understanding. But with that, let's get started. It's funny how things are changing so quickly these days. When I started designing and planning this webinar on policy in a post-COVID era, it was about 8 weeks ago. And it looked like we were going to be approaching a post-COVID era. I guess not, or we are entering a new phase that, even though the national picture is changing rapidly, regionally, it really depends on where you live. If you're in the southern part of the United States, in the Southeast, your challenges with COVID may be greater than those of you living in the Northeast. If you live in the upper Midwest, it might be a different challenge than the Pacific Northwest. It's all over the place. So a lot of the legislation we're going to talk about kind of was transitioning out of the COVID focus in Washington and into other things. And, well, we may be going back to the drawing board, but we'll see. So we've already done the introductions. Andrew Kessler, I represent BHAP as well as some other organizations, all in behavioral health, mostly in substance use disorders. I've been doing this for I've been doing this with Slingshot Solutions for about 13 years, and I've been working in Washington D.C. in behavioral health for about 20 years, plus some time on Capitol Hill. So this is what I do. This is all I do. Like many of you, provide either treatment or recovery services. It's my life policy. So let's get to what's going on. Well, COVID-19, as we all know, I don't need to tell you the actors, the providers, how bad the impact has been. But the last few days or the last few weeks have given us some news that really illustrate how hard it's been on the population we serve. And of course, let's keep in mind, it's not like we had all the resources we needed before the pandemic came around. This was a problem that had us in quite a hole even before a global pandemic. So, obviously the challenges that were presented to us hit us fairly hard. There's legislation being introduced on SUD issues not related to COVID. The White House is engaging. Progress is still slow. Things don't happen fast in Washington unless there is an absolute 100% 9/11 size emergency. Even with the COVID response plans, even though the first few stimuli under President Trump got out fairly fast, when it came to the really big multi-trillion-dollar deals, you saw how slow it was, how much time it took. Things don't move fast in Washington, unless, of course, you tell everybody that you have plenty of time, and then they happen overnight. But things move slowly. I've often compared advocacy to substance use disorder treatment and recovery. It's a journey. It's an arc. Each day brings something new, a new challenge. You deal with the challenge. You move along to the next one. But things don't happen fast. It's a marathon. It's more than a marathon. It's an endless marathon. So progress is still fairly moderate, but we are making progress, and we're going to talk about that. So according to the CDC, 2020 was the worst year on record for overdoses. This information just came out last week. We have eclipsed 90,000 overdoses in a single year. A few years ago, during the opioid epidemic, which we're still in, but when it was dominating the headlines, I'd say we were at about 67 to 70 to 73,000 in that range year after year. I'm talking 2016, 17, 18. We were steadily climbing up from 60s to 70s. We hit 73, I believe, in 18. In 19, it ticked back down, or it held steady for the first time in a long time. But now it's just off the charts. I don't want anyone to think that this is simply a one-to-one. We had a pandemic. It had a severe impact on behavioral health. Overdose numbers increases. This is not true. The numbers were ticking up pre-pandemic. So I told you in 18, we kind of didn't go up, and we were all kind of happy about that. In 19, we saw another 5% increase. So it was already ticking back upwards before the pandemic. So the provisional data shows us 93,000 deaths, a 29.4% increase over the previous year, and the largest increase in 3 decades. 3/4, and this is preliminary data. CDC is still doing some really deep dives in all of this. 3/4 of the overdoses involved opioids, which include fentanyl, and 56,000 of the deaths overall included fentanyl. This fentanyl not only being a primary driver in the deaths, illicitly manufactured fentanyl. We're talking manufactured in a lab, fentanyl analogs, illicitly manufactured, not manufactured for medical purposes and then diverted on the black market and abused. We're talking illicitly manufactured from the get, is a primary driver. It has increased 38% from May 2019 to May 2020. And cocaine has also increased 26.5%. And the deaths in which cocaine is involved in large part linked to either co-use of cocaine with illicitly manufactured fentanyl, or the cocaine itself was laced with illicitly manufactured fentanyl. So fentanyl is the driver, whether it be pure, whether it be illicitly manufactured, whether it be taken in addition to another drug or lacing another drug. Fentanyl is the issue, plain and simple. That's where we are. It's all about the fentanyl. Combine this fact with treatment is down. RTI's Research Triangle International, in the research world, they are, if they were a soft drink, they'd be Coca-Cola. There are some research firms that when they produce a study, and some research organizations, when they produce a study, you take notice. NORC is one of those, Rand Corporation, Pew, RTI is up there with those groups. And Research Triangle found that initiation of treatment by patients is down 28% in California, where they did the study. To make matters worse, the justice involved populations and the Medicaid populations, which are very largely represented in our work, were hit especially hard when it came to seeking out the initiation of treatment. This is a result of resources being less available, staff being less available due to the pandemic, staff being less available due to a lack of equipment like PPEs, not knowing how to deal with the pandemic early on, not knowing how to deal with testing, not knowing how to deal with inpatient settings or versus outpatient settings, a variety of issues. So while overdoses are going up, initiation of treatment is going down. That's the situation we're in. I want to take you back to last March. It's been almost 6 months, but that was about when I did my last webinar for BHAP. I've done other webinars for other organizations. I know there's a lot of crossover. Some of you may have seen me present for maybe, CCAP or the, NCAD conferences. There's a lot of crossover, and I present in a lot of different arenas. So, but for those of you who haven't seen it, let me break down how COVID legislation helped impact this problem we're having with SUD. So the American Rescue Act was Biden's signature response. This was all the Biden administration worked on in the first couple of months of their White House. And what they did was they put $1.5 billion into the SAPT block grant. That's the Substance Abuse Prevention and Treatment Block Grant issued by SAMHSA, which goes out to the states. States get money based on a population formula and population alone. California gets the most, Wyoming gets the least, everyone else falls in between. So the American Rescue Act added $1.5 billion to the block grant. They also added $1.5 billion to the mental health treatment block grant, which also goes out to the states. Add this to the money given to the block grant by the previous stimulus act under President Trump in December of 2020, and then add regular fiscal year funding, and states are going to see about triple in their coffers for block grant funding than they usually see. Now, while this sounds like good news, the problem is when states get hit with that much money at once, they often are not quite sure how to spend it. You can't just do it willy-nilly. You've got to have a plan. And you can't just keep giving the same people more money. You got to make sure you know where the state needs to know where are the providers, where are the hot spots, where are the problems, how are we going to make things more equitable and more efficient with this newfound stockpile of funding. In order to accommodate the states, what the federal government has done is giving them 2 years to spend it down instead of one. Usually on a federal grant, from SAMHSA, when it has to do with block grant funding, the state has 1 year to spend the money. In this case, states will have 2 years to spend down the money, which gives the states a little breathing room, and is necessary. As dire as things are, one of the worst things we could have done was tell the states they had to spend it down in 1 year, because we saw what happened with the state opioid response grants a few years ago. States got hundreds of millions of dollars to spend on opioid response and had no idea what to do with it. They were just overwhelmed. So they have a 2-year window for a spend down. Now, in the American Rescue Plan, the same legislation I was just talking about from March, there were other provisions for other pieces of funding dealing strictly with substance use disorders. And I've listed them here. I'm not going to just read them. You all, can read as you see fit. But I do want to give you some highlights. So $50 million will be set up in a grant program at SAMHSA, which is funding for community-based and local behavioral health needs. You can see this money will go to addressing increased community behavioral health needs worsened by the pandemic. This will be a separate pot of money by which communities can apply directly. States, municipalities, tribal governments can all submit their grant applications to SAMHSA to see if they qualify for any of this funding. I don't believe this has been made available yet. I would suggest all of you go to the SAMHSA website and sign up for grant alerts, www.samhsa.gov, and you can sign up for alerts, and you will then be notified when these grants are made available for you to apply for, if you are so interested. Also under the American Rescue Plan, in this same provision, is what this money can be used for: training the workforce, addressing surge capacity for mental health and behavioral health needs, and expanding mental health and behavioral health preventive crisis intervention services. This looks like it's really complicated legislative language, but it's not. It's actually quite simple. You can see in the second paragraph there, $100 million will be made available for behavioral health workforce education and training. This is a program at an agency called HRSA, Health Resource Services Administration, called the BWET program, Behavioral Health Workforce Education and Training. And you can see this is a training program for professionals that are establishing or expanding internships or other field placement programs in mental health, psychiatry, psychology, psychiatric nursing, social work, substance use disorder prevention and treatment. Anyone who works in behavioral health is eligible to apply for these grants in order to expand their training programs to encourage more professionals to enter the field. That was also in the American Rescue Plan. The plan also had some new authorizations. That's just a fancy word for creating new programs in Washington. It requires the secretaries to look at potential violations of parity, which we know certainly exist. And it requires these secretaries to publish an annual report with a summary of their comparative analysis of parity plans as they deem appropriate. So parity, as you know, was a big win for us back in 2008 at the policy level. Now the struggle for the last 12, 13 years has been to enforce it, which has been sorely lacking. So that was placed in the American Rescue Plan as well. There's another piece of legislation that some of you may have heard about. I know that you all are on different newsletters. You get different alerts, some from BHAP, some from other organizations, National Council for Mental Well-Being, NAZADAD, CADCA. It's an alphabet soup. And we all have different focuses, but we all get the same information. And in your experiences, you may have gotten information on a piece of legislation called CARA 3.0. And let me give you a little history here. 5 years ago in 2016, Congress passed and President Obama signed CARA, Comprehensive Addiction Recovery Act, that really kind of planted a flag that gone were the days of addressing substance use disorders solely as a criminal justice issue and embracing more of a public health and treatment approach. Created lots of new programs for treatment, recovery, so on and so forth. It was followed by the Support Act of 2018, which did the same. And now we have CARA 3.0. This is the brainchild of Senators Portman of Ohio and Whitehouse of Rhode Island. And it is a fairly expansive, I don't want to say all-encompassing, but very broad, casts a very wide net for all aspects of substance use disorder prevention, treatment, and recovery. Senator Portman will be retiring at the end of his term. We kind of see this as maybe his swan song. And there are investments, as you can see at the bottom of this page, across the board. I want to make something clear. The bill I was just talking about, the American Rescue Plan, that has been signed, passed by Congress, both chambers, signed by the president, enacted. It is law. CARA 3.0 is not there yet. It is simply on paper. It's been introduced in the Senate and in the House by Congressman David Trone of Maryland, and it's sitting there. And that happens. Remember I said before at the beginning, things don't happen fast. Sometimes they move at quite a glacial pace here in DC. So the bill is waiting for action, but I want to tell you what's in it because it's fairly important, and it really could change the resources we have to deal with substance use disorders. On the workforce front, it authorizes $55 million for HRSA and the Behavioral Health Workforce Education and Training Program, which I mentioned, which would not only be eligible for every type of behavioral health employee from psychiatrists all the way to peers, which is a very popular subject on Capitol Hill. If you want to talk to someone on the Hill about workforce these days, they want to know what you're doing about peers. There is an investment in a workforce to include peers. That would be at the Health Resource Services Administration. It would establish a pilot program through SAMHSA to address SUD prevention workforce challenges. If you think treatment is understaffed, you should see prevention. The prevention workforce is just not there. I represent the ICRC, which is responsible for credentialing. I'd say across the nation, we have maybe 2,000 prevention specialists. It's not enough. These are people who often work in community anti-drug coalitions. They work in community settings. They are often credentialed or licensed, whatever word you want to use, and highly trained. I would say the one area, if I had to pick, where we are grossly underinvested, it's probably prevention. Although recovery and prevention, probably fight for that honor. But any disease, you want to cure to any disease, the answer is prevention. You want to fight lung cancer, the way isn't better chemo and more chemo, it's stop smoking. You want to stop AIDS, it's not more drugs and AZT, it's safe behavior. Prevention is the key to any public health crisis. It's not the vaccine that's going to protect you so much as a mask. Prevention. So this investment in prevention we feel is quite important. Another area gaining a lot of interest on Capitol Hill is recovery housing. And the bill would require SAMHSA to address the issue of quality recovery housing. Lots of recovery housing exists. That doesn't mean quality recovery housing exists. States are pretty much on their own when it comes to monitoring and regulating recovery housing. So the best SAMHSA can do is provide incentive. So as you see, grants to states would ask the states to implement guidelines of the National Academy of Sciences, which had input from NAR, National Alliance of Recovery Residences, and improve quality settings and also fight the discrimination in many recovery houses against MAT. It's 2021, we've come a long way, but we still experience a lot of recovery housing settings where they are opposed to anyone utilizing methadone or buprenorphine living in their facilities, which just or we can't accept. So there would be an added incentive to educate the recovery housing community on the benefits of MAT, and it would be a requirement for receiving one of these grants. It would create an interagency working group to increase collaborations among federal agencies on the availability of high quality recovery housing. And speaking of recovery and recovery housing, we also have investing in recovery support services. Currently, if you were to look at all programs in SAMHSA, add up the total and see how much is invested strictly in recovery support services, funds dedicated strictly to recovery support services, you wouldn't crack 30 million. You wouldn't. Now, states can use block grant funds and state opioid response grant funds for recovery if they so choose. But when it comes to money dedicated to recovery support services, it's sorely lacking. It comes as a surprise to no one when I say treatment is for a set period. Recovery is for a much longer period. So we view recovery as kind of central to our success. So the bill would authorize $200 million to build connections between recovery support services and networks, including treatment programs, mental health providers, so on, in order to develop recovery wellness plans that address barriers to recovery, social determinants of health, better telehealth access, any number of things. It's not just about providing the services, it's about building the infrastructure. That's where this bill goes. The previous bills haven't. In addition to that, there would be an additional $50 million in grants to peer recovery services to provide continuing care and ongoing community support. So $250 million investment in recovery. We're currently at SAMHSA. It's at what, 30? I said, we're talking about a substantial increase. This is an issue that I work on representing the workforce. Reimbursement. What can you say? It's not where it is. We get Congress telling us do more, hire more people, hire better people. Well, with the reimbursement rates we face, especially from Medicaid, that's hard to do. No one gets in this field to get rich. So this would commission a GAO study examining the reimbursement parity between substance use disorder services and other healthcare and its effect on the SUD workforce. If you want to hire the best and the brightest, you've got to pay for the best and the brightest. That's basically our bottom line. So evaluating the disparity in reimbursement between SUD professionals and other healthcare professionals is our first step in making it clear to Congress that the workforce shortage we face is not for lack of interest. There are economic and social issues that affect us that we must address. I'm particularly proud of this because I wrote this provision. So, it's that's how it works. So, for those of you who think I just present on webinars all day, so that would also be in the CARA legislation were it to pass. So that's it for the substantive legislation. I'm going to get now into a little more of the politics of what impacts our work in Washington. I've got about 20 minutes left before I stop and we take questions. And what I want to point out is that there is a difference between politics and policy. Politics is what you see on the news. You may watch CNN, MSNBC, Fox, ABC News, NPR. The stories you hear about Washington, about Nancy Pelosi fighting with Mitch McConnell, about President Biden developing infrastructure packages to send to the Hill, that's politics. Okay? I work in policy. We actually write legislation and we pass it and we get it done. It doesn't make the evening news. We make changes that are for the benefit of the causes we represent. However, every so often those two worlds collide. None more so than during the opioid epidemic and ever since. The more popular an issue becomes in Washington, the more politics creeps in to the policy. For example, think of the HIV epidemic. People in the early 80s who wanted more biomedical research and wanted to know more in terms of how the disease was spread were very loud, but a marginalized group that was not taken seriously. So they were working on policy. We want more research. Eventually, it became politics. We want the president involved. We want more of Congress involved. We want you to talk about this in the State of the Union. We want you to come to San Francisco and learn more about this. And as politics creeps in, the policy starts to change. So, with the Biden administration, what you have to understand is this is the first administration that I've ever seen that has come into office with a plan to address SUD issues. It is nowhere to be found in the 2008 Democratic platform. It was nowhere to be found in Barack Obama's priorities. If you look at the 2016 priorities of President Trump, it all focused on the border. It had nothing to do with treatment. This is the first time a president has taken office and said in his platform, on his website, this is what I'm going to do to address the issue. So this is an exciting time. Now, as I said earlier, President Biden in his first 2 months was 100%, without fail, laser focused on the COVID pandemic. Not surprisingly. Starting in April, we started to get an idea of how his policies would take shape for substance use disorders. Now, you see on this slide, ONDCP, that is the Office of National Drug Control Policy. Some of you may know it as the drug czar. Those of us in DC who work on this issue, we don't call it the drug czar. We call the person the director of ONDCP. So this is where we're at with the president's priorities. In April, I believe April 1st, he announced these 7 priorities for his administration. You can read them for yourself. You can see they're pretty diverse, cross-cutting. And this is where we're going to go. Expanding access to evidence-based treatment, nothing new. Advancing equity, nothing new. What is new and what is rare and never before seen from the White House in my time working on this is harm reduction. You see it in enhancing evidence-based harm reduction efforts, and you see an emphasis on recovery towards the bottom. These are fairly new. The reason this was done is because every president must report to Congress, usually by May, on an annual national drug control strategy. Well, the president wasn't going to make the May deadline. Between a new administration, the pandemic, everything else, they weren't going to make it. So what they did instead was saying, here are our pillars, and we're going to go forward from here, building our strategy. What I want to talk about is harm reduction. As long as I've been working on this, harm reduction has been controversial. Whether it's the name, whether it's the approach. However, there is no denying the science behind harm reduction. It works. Whether it's fentanyl test strips, safe injection sites, syringe exchange, call it whatever you want. It works. As a result, everyone I work with, I say to them, be guided by the science. So I've said to BHAP's leadership, if the science says harm reduction works, we should support it. So you see here some of the plans of the Biden administration. Naloxone availability, obviously always a big thing. The Trump administration did well with their naloxone distribution. They made it a fair enough priority. They didn't discredit it or think it unworthy of their time. So naloxone distribution kept up under the Trump administration. We'd like to see best practices for FTS services. For those of you who don't know FTS, you're going to learn a new initial today, fentanyl test strips. You'll remember I opened by saying the problem is fentanyl. Now, test strips exist by which you can utilize them and determine if a identifiable amount of fentanyl is in the narcotic you're going to use. If it is, don't use it. If it's not, you're safe to use. Now, many people would say, well, they shouldn't be using in the first place, and we know that. But that's why it's called harm reduction. We're trying to prevent overdoses here. So fentanyl test strips, big part of the strategy. There's also advancing recovery-ready workplaces in the addiction workforce. Same things I mentioned before in CARA 3.0. So the president and Congress seem to be fairly in lockstep on that. You'll remember I mentioned under CARA 3.0 the examination of the workforce that was called for. The middle paragraph here, you'll see they want to see a landscape review of existing programs and conduct outreach to state and local governments and members of the workforce as to recovery, barriers, whatever the case may be. More on workforce training for clinicians in addiction with special emphasis on community-based services, of course. Working with the Veterans Health Administration, the Indian Health Service, providing guidance where it may be needed. This is a bold plan, and we'll learn more when the president submits his actual narcotics policy statement to Congress, hopefully this fall. They're still gathering comments, but it's ambitious. But it really does go across the board: prevention, treatment, recovery, harm reduction. It's got it all. So we're trying to temper our excitement, but we're moderately pleased with that approach. And of course, an expansion of recovery support services. I've only got about 10 minutes left. So I want to make one final point about harm reduction and then want to get into something else. Last year, the first safe injection site was scheduled to be opened in Philadelphia after a series of court battles. However, the Trump Department of Justice stepped in and fought the opening of the center, which remains empty. This year in 2021, Rhode Island indeed did open the nation's first safe injection site where fentanyl test strips are available and naloxone is on hand. So naturally, all eyes are on the Department of Justice, which appears to be not stepping in the way and claiming any kind of federal jurisdiction. So if the DOJ remains quiet, that facility should be operating at full speed fairly soon. Government isn't always about what someone does. It's often about what someone does not do. It's kind of how we got to where we are with marijuana. Obama said, I'm going to let the states do what they want and not interfere. It was called the Cole Memo. The Trump administration chose to have their DOJ fight safe injection sites. The Biden administration is choosing not to. So, and also the Biden administration made a change that now allows federal funds, grants, to be used to purchase fentanyl test strips, which had not been allowed under the previous administration. The last thing I want to talk to you about is the budget, because as you know, all of these ideas are great, but they go nowhere without funding. Personnel, resources, they cost money. There's two kinds of policy we work on in DC. One is regulatory, changes in the bill's language, like I was talking about before, training for workforce, evaluation, including recovery for certain grants. Those are regulatory changes. Those are language changes. And then there's money. Someone such as myself, I'd say, depending on the time of year, I could be spending 80% of my time on the funding. All these programs I just talked about don't go anywhere unless the appropriations committees in the House and Senate say, here's the money to do what you need to do. In the Support Act in 2018, where something like 60 to 70 new programs for SUD issues were created, I have a list that thick of the ones that remain unfunded. So what did we do? We created new programs, but we didn't fund them. Funding is not everything, but it's 99%. So, of course, we were all waited for President Biden's budget with great anticipation. In a normal year, the budget is released by the White House in February. Well, he had just been sworn in. We had a pandemic to deal with. So instead, we got the budget on Memorial Day. You say, okay, so you had to wait a few months. Problem was, with the process the way it is, the White House budget is not binding. It's simply a recommendation. It's Congress that determines the numbers that will be in legislation. Congress already started their work well before they got the Biden White House budget. So we didn't really know where the White House was going to come down on funding certain programs. So that made making requests of Congress a little tricky. Well, the president really delivered. The president recommended increasing the SAMHSA SAPT, Substance Abuse Prevention and Treatment Block Grant, from $1.8 billion to $3.5 billion. That's I think that's a 90% increase. The House of Representatives said, nice try, but we're going to go with $2.8 billion. Still, it's $1 billion increase. And nothing to sneeze at. And this would be the first increase in the block grant in 13 years. I'm going to show you why that's important. This is a chart of block grant funding from 2006 to 2018. You can see in the straight line at the top, it's flat. Now, some programs in Washington, especially during tough fiscal times, and believe me, I've been through these years and these cycles, say, if you didn't get cut, that's good. Take the level funding and be happy. Well, for a year here, a year there, I remember some lean years in funding, 2016, 2015, where you take it. But when you're flat for 12, 13, 14 years, and you don't adjust for inflation, especially healthcare inflation, you're losing purchasing power. And that is the dotted line. So as you can see, in 12 years, with no increases, the block grant for substance abuse prevention and treatment services lost 31% of its purchasing power. It's no good. That's why we needed this increase. We also need the increase because we're sorely underfunded. This is just illustrative of that. Give you an idea of the amount of substance use disorder treatment and prevention funding passed through to the states. You can see it started to go up a little bit in 2017 because that yellow is the state opioid response grants, which kind of brought us up a little bit. Look at the increase between 20 and 21. That's a result of the COVID bills I was talking about, with all the money coming in. What this White House is seeking to do is try and keep it where it is. We can't quite do it because you can't be passing $1 trillion COVID packages every year. And we know that money's going to be gone soon. So what we're trying to do is make up for that in future years. It's a pretty, so what you really should be doing is comparing 2020 to 2022. Because the SOR, state opioid response grants, which again go to each state based on population, but the states with the highest overdose rates get a bonus amount of grant funding. That increased from $1.5 billion to $2 billion in the president's budget and in the House. Probably the biggest news is the White House recommending a 10% set aside in the block grant for recovery support services. The SAPT block grant, the way it is now, each state must use 20% of their funding for prevention. The other 80% is theirs to use as they please. treatment, prevention, recovery, what have you. This year, the president recommended, and the House agreed, that there should be 10% of the block grant set aside in each state for recovery support services. Now we wait for the Senate. When I keep saying Washington is slow, what I really mean is the Senate is slow. We have a saying in Washington. The Senate moves at two speeds, glacial and whatever is slower than glacial. So it's going to take a while for us to know straight up how much funding are we going to get? Are we going to get the 10% set aside? How are we going to do? It's in the Senate's hands. So I want all of you to know the president agrees to a lot of this. The House of Representatives agrees to a lot of this. The Senate is a very different ballgame. There's only 100 people as opposed to 435. Each senator exerts outsized influence as a result. And there's only so much money to go around. Senate numbers are always lower than House numbers. They're more fiscally hawkish. And each senator has pet projects within certain agencies that they demand be funded. And sometimes that takes money away from other projects. So the Senate is a much different battle. And we're going to be waging it for the next 3 months at least, if not more. We may not have an answer to this probably until the holidays. So off to a good start, long way to go. I want to talk a little bit more about that recovery set aside. You can see here, as laid out by the House of Representatives, these are the 5 areas where the funding could go. Developing recovery support institutions in communities, peer coaching, community-based supports necessary to sustain recovery, including things like transportation or job training or educational services. So it goes beyond the clinical. Provide activities to reduce stigma and provide technical assistance. So that's what the 10% set aside would be limited to. They would also support operating costs for organizations to provide the above services, prioritizing those with leadership and governance that include representation from people in the recovery community itself. We want the recovery community involved in these decisions. In the budget, HRSA, the Health Resource Services Administration, scheduled to get about $180 million in money for loan repayment programs. This would be up from about 120. 155 million is for NHSC, which is the National Health Service Corps, and 28 million would be in a different program at HRSA available for all SUD professionals, from psychologists to social workers to counselors would be eligible for this program. So. Right at 1:50, I like to leave 10 minutes for questions. Conclusions. We have a new White House with new priorities, which presents us with a potential opportunity. As I said, the impact of COVID is not going away anytime soon. Even if we are all vaccinated, the number of overdoses and the behavioral health issues we've had to deal with are going to remain. And as always, the crystal ball is not clear. People always ask me if you had to guess. And my answer is, it is a guess, because I haven't met the person yet who always gets it right when making predictions about politics and policy in Washington. So I thank you for your time. If you have any questions, you can either put them in the chat box, or Angie can moderate. You get my contact information right there. And thank you for your attention.
Don asked, are there any advocacy actions we can take to help advance CAR 3.0 in the House and Senate within the Biden administration?
Yes, absolutely. The first thing you always want to do is contact your members of Congress, whether it be in the House or Senate. Find your member of Congress, shoot them a note saying, please sponsor or co-sponsor, this bill, please advance this bill. Whatever the case may be. A good resource for CARA 3.0 is trying to think of a place where you can go to find updates. Well, Obviously, you can stay in touch with BHAP through our website and our policy updates, because we always have policy updates there. But if you want to learn more about it, I would recommend going to Googling CARA 3.0 and going to the websites of Senator Portman of Ohio or White House of Rhode Island. You'll find everything you need to know there. And call your members of Congress and say, we support this bill. We want to see it move forward. I mean, it's not a matter right now of opposition. Our biggest enemy in Washington is always the same thing over and over again. It's the calendar. There are only so many legislative days in a year. There's a lot to do. It's not a matter of members of Congress saying this is a bad bill. The last iteration of CARA, I believe, passed 96-1. Or I'm sorry, 95-3. 95-3. So yeah, it's not a matter of support. It's a matter of momentum. So contact your members of Congress and say, we want to see this bill move.
And I put in the chat that BHAP has a Find Your Representatives page where you basically put in your address and it gives you local, county, state, and federal representatives. So you can find that information pretty quickly on the BHAP website. John wants to know, do you believe that residential recovery support services should have Narcan or naloxone on site on hand? Does this require a prescription?
Yes, next question. I believe everywhere should have naloxone or Narcan. I mean, I don't see the harm, I'll tell you that. So it's, that's an easy one. Yes. No ifs, ands, or buts.
Feel free to continue putting your questions in the chat. How do you see the rest of the year playing out, Andrew?
Well, like I said, the calendar is the big enemy. When it comes to the budget, we see the Senate probably giving us the numbers that they're, going to be starting with sometime in late September. And then the back and forth between the House and Senate begins. I have not seen the budget's supposed to be finished September 30th. That hasn't happened in 9 years, maybe. So we get what's called a continuing resolution. Those of you who watch the news are always saying, is the government going to shut down? That's what happens when the budget's not done on time and a continuing resolution isn't passed. We're expecting continuing resolutions probably through the holidays, and then everything goes well, we'll have a budget, January 1st. When it comes to the other legislation I'm talking about, like CARA, maybe we'll get a hearing in the fall, but you have to understand Congress works on a 2-year cycle. So, and there's not usually a big push to get everything done until right before the Congress ends. So we could be working on CARA for the next year and a half. Easily.
Great. Feel free to keep putting your questions in. A reminder that we do have advocacy alerts that we send out on a regular basis. I put the link in the chat. You do not have to be a member in order to see these. However, members do receive a specific advocacy alert that Andrew puts together once a month that is only for members. And it's more detailed, kind of like what we got here in this webinar. So there's a benefit for that, but you can sign up for the newsletters without being a member. I put the link in there. Excuse me. Any other questions?
Okay.
Give it a few seconds. Okay. I did put the webinar evaluation form in the little links. That is not for the CEs. That's just a general evaluation form so we can get some feedback as to what you thought about the webinar. Just a reminder that if you fill that out within 7 days, you will get a coupon code worth 10% off. So give it a few. Awesome. Okay. Well, I want to thank Andrew Kessler for presenting today. Thanks as well to you for participating. We hope you join us for future webinars. You can sign up for our various newsletters, which include emails specific to upcoming events at our website, www.bhap.us. This concludes today's webinar. Thank you very much.